the ovarian volume studies for this group of the patients. You all know that these patients do have some clinical symptoms like menstrual problems, they're usually obese, they have acne, they have also hirsutism, and it is very easy to recognize these patients when they enter your outpatient clinic. But of course, a part of having clinical symptoms, you always search for endocrinologic data, and it is abnormal LH-FSH ratio, which should exceed 2.5. Another thing you also want to do is to look for ultrasonographic features of these patients. And knowing typical ultrasonographic features, which is increased ovarian volume, it is easily to be seen that three-dimensional ultrasound is superior to any other tool in measuring the exact three-dimensional volume by 3D ultrasound, and these patients do have increased ovarian volume. Another thing you want to see is the increased ovarian stroma, because these patients do have enlarged volume because they have enlarged ovarian stroma. And using three-dimensional ultrasound, you can clearly measure in a more precise way the ovarian stromal area, but also the volume. Another thing, and the third parameter that the polycystic ovaries do have, is enlarged number of subcapsular follicles. And usually more than 10 follicles are to be visualized at the periphery of the polycystic ovary. And by 3D ultrasound, and with this facility to look each section and to perform numerous parallel sections, you will easily see usually enlarged subcapsular follicles. But please remember that not all the patients do have subcapsular follicles. Some of them have enlarged number of the follicles scattered throughout the stroma, and in these patients we are talking about general polycystic appearance, so not peripheral polycystic appearance of the ovaries. And also very common finding is increased stromal vascularity. If you are doing Doppler findings, you will immediately see that the patients with polycystic ovaries do have increased and very vascularized and hyperechoic stroma. Mucus. In patients with postmenopausal changes, you may have stenosis of the cervix. Due to the stenosis, you may have accumulation of the mucus within the uterine cavity. And this is the thing you can show. But you don't know by your ultrasound whether you are dealing with mucus or blood. Because a patient with stenotic cervix can also have endometrial cancer from the place. She can also, from these changes within the cancer, she can bleed, and the fluid, the blood, can be collected within the uterine cavity. So you don't know whether you're dealing with mucus, whether you're dealing with blood. And therefore you always have to refer about the morphology of the collection of the fluid, whether it is anechoic completely, whether it has any kind of the clots, or how it looks. And of course to express the exact measurement of the fluid collection. Then you also have to report about the integrity of the endometrium. So you have carefully to obtain in each section, in as many sections as you can perform by yourself, you will need color Doppler for functional assessment. Color Doppler is useful for IUGR, but it is not much contributing to diagnosis of fetal anomalies. It is not much contributing to other fields. But functional assessment is very useful in infertility and in oncology. So if you are doing, menopausis, you will need color Doppler and functional assessment. If you are doing infertility, you will need functional assessment. If you are doing any kind of gynecological investigation, you will gain a lot of information from functional assessment. And I think that some data can be collected, let's say 5% of the data by 3D. Because you will see that uterine anomalies cannot be viewed in such a nice way as you are using 2D by 3D. So some cases can be better diagnosed if you are using 3D equipment. And I think that when computers will do for our benefit, I think we will have all 3D equipments. And it will be very simple to do it. Nowadays you have a lot of post-processing to do by yourself. You have to play with computer, and if you are better with handling the equipment, you are better with results. But I think in the future everything will be as simple as to the ultrasound. So it will not require much time. So I think this is the direction that we go. Do you have any questions? So the most can be done by careful examination and evaluation of the lesion. So leiomyomas are usually, I think I have leiomyoma with cystic changes, just to show you the difference. So what is the difference? The difference is adenomyosis has first cystic content part. And this cystic content part are surrounded by hyperechoic layer. And this is endometrium. So this is a cyst surrounded by endometrium. The difference between gestational sac and adenomyosis is that gestational sac has two layers. One is belonging to endometrium and another one to trophoblast. Adenomyosis has one layer belonging to the endometrium. Okay, this is the first difference. Second difference is that myoma, usually, if it is small, it has no cystic degeneration. Cystic degeneration is usually happening in myoma that are over 4 or 5 centimeters. And adenomyosis is usually not that big. Okay? Second thing is that cystic alteration in myoma has no hyperechoic layer that is thick, as adenomyosis has. But it has very tiny lining, because it is a collection of blood, this cystic degeneration. So these are the differences. Of course, you need to see more adenomyosis to be assured. But remember that in adenomyosis literature, they usually refer on Swiss cheese appearance of the myometrium. So if you see multiple cysts and Swiss cheese appearance, do not think of myoma, think of adenomyosis. Okay? If you see a small solitary cyst close to the endometrium, think of small focus of adenomyosis. Okay? But if there are multiple, it is an advanced adenomyosis case. And do not try to enucleate it, you know. Consult your patient if she is young to wait, but then if she is over 45 and is not thinking of any pregnancy and has a lot of symptoms, pain, then think of doing hysterectomy, because enucleation will not bring much to this patient, okay? Because it can, so everything is clinically. I think it's very important to speak as a clinician, because I'm never using ultrasound just for diagnosis. I'm always advising what to do as a second step. So even when the patient is coming just for ultrasound, I'm always speaking about clinical symptoms and asking the patient about clinical symptoms, signs, findings, because I think it is an investigation, but it is ultrasound investigation. But you cannot look at as an isolated form of diagnosis. It should always be clinically applicable. And therefore I think that ultrasound should be done not by technicians, but by doctors. And I think that in the future by subspecialists. I think the different things are looked for by oncologists than by technicians. And also in infertility, I think the technician can measure follicles, but cannot get insight why something is happening. So I think that you are better if you know more, if you know pathology, if you know your specialty, you will interpret each finding in a different way. More you know, more things you will find in your ultrasound examination. And that's why I think it's very challenging, because I think it's very interesting, because each day is different. You see different things. As technology is improving, your knowledge is improving, the patients are different. It's great.
It's a new medicine, you know.
I think it's completely new.
30, 40 years is nothing.
I think even 10 years ago, you know, when we were looking at something, we were looking in a different way. I think now we were using ultrasound for collection of oocytes. You know, it was the main purpose, to see the follicular growth, to see, we are not thinking about quality of the oocyte, about receptivity, about these things. No, we were, when we started doing hysterosalpingography 12 years ago, 11, they were thinking that we are crazy. What they are speaking, how they can see something, you know. But now everybody is using it. So I think, you know, we will definitely change